Great. Um, so welcome. This is our webinar, and we are happy to have an opportunity to speak to people who are working in state legislatures around the country about the importance of addressing healthcare costs and, in particular, helping individual patients with their out-of-pocket fees as well. So let me tell you a little bit about PIRG. If you haven't heard of us before, we got our start 50 years ago on college campuses around the country, working to win consumer protections. Today, we have members and supporters in 24 states. You'll see our map here. And we work at both the state and the federal level on policy reforms to create a healthier place to live. Our high value healthcare campaigns focus on the value of care. That is the value of every healthcare dollar that we spend on healthcare. Are we getting good quality care? Are we spending our healthcare dollars wisely? A few years ago, we explored a new type of bill that people were telling us about. Patients who never stepped a foot in a hospital were not only receiving bills from their regular provider, but they also were receiving bills from healthcare facilities. So what and those people were shocked, right? Why are they getting a hospital bill when they've just seen their doctor? But they looked at the charges closely and they found out they were being charged a facility fee. So what is a facility fee? Facility fees are charges from hospitals that ostensibly cover their specialized overhead costs. They're separate from the bill that is sent by the doctor or other professional who are charging for their time and labor. So these facility fees are bills that are coming directly from the hospital, and they're becoming increasingly common as hospitals expand the range of services that they provide, from specialized inpatient tests and procedures to more routine outpatient care. As large hospital systems buy up independent provider offices, what's known as vertical consolidation, more patients than ever are exposed to the facility fee charges. Today, a hospital setting could include sites of service miles away from the hospital's main campus where there's no emergency room, no intensive care unit, and patients aren't admitted overnight. Yet, patients who receive care in such locations may nonetheless be charged a facility fee. So let me explain by telling you how it worked for two patients who reached out to us. Next slide, please. So this is a picture of Todd, who lives in California. This is a state without any facility fee protections. He reached out to us with his problems on facility fees. He suffers from pain in his spine and he needs injections to relieve that pain. So he described two examples of facility fees, but he's received many facility fees in his time of getting care. The first was a $400 facility fee charge for a telehealth appointment. So if you think about what we talked about with facility fees covering hospital overhead and hospital services, the telehealth appointment, certainly to Todd and to us, doesn't seem like it requires an additional facility fee. He needed that telehealth appointment in order to get approval for his shot. The second facility fees he encountered came when he actually went to the doctor's office for the injection to relieve the pain in his spine. He told us that he was charged facility fees, often double or more of what his copayment was supposed to be, and for at least a dozen routine visits, tests, a Zoom appointment, and multiple phone calls. Todd, fed up with the charges that he feels are shady and dishonest, tried to avoid these fees, but he found that every doctor on his plan of in-network providers was affiliated with a hospital and charged facility fees. He even asked his insurer if they would cover a doctor not in their insurance network, since all the participating providers were going to charge him this facility fee. His request was denied. He filed a grievance, which was also denied. He explained that when you go to a hospital, the denial explained that when you go to a hospital, there will be additional facility fee charges. But he responded, I never went to a hospital. And sometimes during phone conversations, I wasn't even within 35 miles of the hospital I was being charged facility fees for. He even considered getting injections without using his insurance, since those seemed to be less expensive, but still cost him $600 out of pocket. We connected Todd with an NBC national investigative reporter who covered his story on the national news and went through his bills. And on the next slide, you'll see what they showed. So you can see the facility fees add thousands of dollars to Todd's bills. Even if he could get his insurer to pay these fees, it just means that our insurers are overpaying for services that are happening, could easily happen in an outpatient setting with routine care, but yet we're seeing these hospital level prices. If you're curious about the other miscellaneous charges, the 0272 is a sterile charge, I guess, to have a sterile room in which to give these injections. And the other 0636 is a is a code for drugs requiring detailed coding. But regardless, the shocker here really is that facility fee. Let me share one more story with you. On the next slide, we heard from Brian, who called from a small, mid-sized town in Texas. Texas is a state that has very limited facility fee protections. Passed during the COVID pandemic, the facility fee protections that the Texas legislature enacted prohibited facility fee charges for those drive-through services that we were seeing, such as vaccines and testing in outpatient settings. So those are the only protections. Brian had facility fees charged for both preventive checkups and when he went to the dermatologist. Each time he had to pay more than $100 out of pocket for these facility fees. You can see his bills here, right? These are just a couple of them. So there are two separate charges for the same day, the same office visit. One comes from the doctor and a much higher one from the hospital. Brian, just like Todd, contested the charges but was unsuccessful. He was told the hospital was legally allowed to charge these facility fees, and the hospital threatened to take him to collections if he didn't pay. So he swallowed, put it on his credit card, and he's been looking into switching providers, but most places, again, like Todd in his community, are owned by the hospital. So Brian's solution to avoid more charges like this is that he skipped his annual physical last year, and he avoids the doctor whenever he possibly can. He wanted to come to the Texas legislature last year when there was a hearing on a facility fee protection legislation, but he wasn't well enough. But he would love to see reform policies because he says that the issue is causing him more disappointment and emotional conflict in his life than he ever thought possible. So these are just a few of the people from around the country who have reached out to us about their facility fees. The names and faces are different, but really the story is essentially the same. They had no idea the facility fee was coming. They can't understand why they have to pay hospital fees for routine and specialty care. And they have no way to avoid these charges because most of the providers in their community are owned by a hospital system that sends the facility fee bill. So after we got these calls from patients, we launched our campaign to support efforts to pass state facility fee protections. And on the next page, you'll see the launch of our campaign with our report, Outpatient Outrage. This was our first attempt to kind of quantify the stories, explain the situation, and raise the issue and raise the alarm so we can have more protections. We'll be updating this report. We're actually in the process right now and releasing it in January. And we'd love to work with you in the state legislatures to explain the report, maybe have an oversight hearing around this issue, and draw more media attention to it. So please reach out to us if you're interested in that. But now that you have a sense of the problem, we'll turn to Senator Looney to share about his journey to address high healthcare costs in Connecticut, and specifically how he managed to pass important facility fee protections in his state. So thank you, Senator Looney, for joining us today.
Oh, well, thank you. It's wonderful to be with you today. And this is a subject of national interest, as we know, and provides, as you pointed out in those cases, real hardships and really a sort of arbitrary system of charging, because we know in many cases when you have a hospital-related facility providing the same service where the same care may be provided on an outpatient basis in a non-hospital related facility prior to its being acquired by the hospital. You have a case where the same provider is providing the same service at the same location, at the same equipment, and then all of a sudden it is subject to a facility fee when it is part of the hospital network as opposed to when it was provided by a freestanding community facility. And that really is just inequitable. And we became aware of that in Connecticut sometime around 2012 or 13. My counsel, Dina Berlin, who is on the call, is someone who has been working on these issues since I first became majority leader. She's been working on healthcare issues for 20 years as our counsel, and really was a key in helping us with the passage of the facility fee legislation that we worked on in 2014 and 2015. We were able to do it in a bipartisan way. It started when I was a majority leader and then became president pro tem in 2015. Obviously, Connecticut is not a state that has term limits, so we were able to do things over a longer period of time and build incrementally. I had the good fortune of working with a Republican partner, Senator Len Fasano, who was also interested in these issues, and he was the Republican minority leader at the time. He also was interested in health equity. He was the son of a very popular community physician and who practiced in Greater New Haven, was an old-fashioned family doctor, a primary care provider, and he became aware in many ways at the same time that I was about how community physicians were being squeezed and how various kinds of price gouging were starting to be undertaken. So we joined together to have a series of informational hearings over a period of 4 months in the interim between the 2014 and 2015 legislative session. We drew broad input from policymakers and also the state attorney general, state controller, who were our statewide constitutional officers, the healthcare advocate, the state departments of insurance and public health. And we had involvement with both large and small hospitals, the Connecticut Medical Society, representing the doctors, independent providers, employer representatives, and we also had some contact with out-of-state folks from Massachusetts and Rhode Island who were dealing with the same issues around the same time that we were. I wanted to move on, and we were seeing a rapid consolidation, purchasing of physician practices. That was a particular concern to Senator Fasano, who saw physicians like his father had been being under great pressure to have their practices acquired first by hospitals, but then later by private equity and other kinds of entities, and a consolidation of the market and large health systems gaining much greater market power. We saw one of the things was that some of the hospitals decided to independent community physicians from following up with their patients when they were hospitalized and having their care turned over entirely to hospitalists and not having the traditional role of the community physician seeing patients when they were hospitalized. So that became a concern. Market consolidation, as we see, is resulting in higher costs, both for payers and for consumers and patients. And we felt the need to amass a lot more data to find out exactly what was going on and to try to find a way to provide meaningful price and quality controls, because this seemed to be something that was spiraling out of control. And we were hearing from community physicians as well as from patients who found themselves being gouged by the changing system. We can go to the next slide, I guess. So again, as I said, hospitals were purchasing physician practices, and that hospital employment of physicians grew by more than 50% in that decade. 60% of primary care doctors and 50% of surgeons are now employees, and consolidation in terms of cardiologists no longer being in private practice, and a major shift, and that a growing concern about the loss of independence and the consolidation of physician practices, and a concern for patients about losing that close connection between a provider who was an independent provider as opposed to one who was part of a larger system. We hear reports from physicians all the time who are part of larger systems that the staff in their offices often are people who are reassigned randomly to some other provider when they're all part of the same system. And one provider told me that, I don't know whether the assistants or clerical personnel in my office are going to be the same people from month to month because they are controlled by the larger system of which they're all part. So there's a growing problem in this area. So we can move on to the next slide. And again, there was the concern was that as of 2014, when we did that study, 22 or 29 Connecticut hospitals charge facility fees, and they can range substantially from minimal to over $1,000. And sometimes facility fees were as high as $5,000. So that became a growing concern that by 2021, facility fees for routine doctor visits and cardiac imaging tests alone at that time would cost Medicare an extra 2.3 billion, 590 million out-of-patient costs. So it's a growing problem, even a growing concern about MedPAC recommended eliminating Medicare reimbursement for facility fees related to outpatient services that historically been provided in physician offices. So this is a growing problem nationally, and we believe that there was need to try to do something about it. In Connecticut, challenges, of course, are very strong here. The Hospital Association is a very powerful lobby. The insurance industry is as well. We're frankly a little surprised that the insurance industry was not more engaged as a partner in this because obviously they are paying more as a result of the services that they are being billed for. Even if the coverage is not the whole cost of what's being asked for, it's still more of a payment for the insurance company. So we would have thought that they would be a stronger ally on this. I suppose they were happy enough just to, if the costs were passed along and somebody was going to pay, they weren't really concerned that much about who. But I think that they should be, given the fact that they're being presented with larger claims as well. Yeah. And again, we said employing physicians is not achieving better costs, or it's just achieving better profits, and without any concomitant increase in patient care or efficiency. So that again, when a physician practice is acquired by a hospital, costs for the very same care go up dramatically. We had a report that these perverse financial incentives were inducing hospitals to buy up practices at the time in order to generate revenue through facility fees, and that we know that this is something that is growing in concern, and that's why we wanted to try to provide some leadership in Connecticut on this, and we did have bipartisan support for it. So we had 11 bills on specific topics, and the bills were combined into one bill, which was Senate Bill 811 of that 2015 session that emerged from the hearings that we had in the interim in the summer and fall of 2014. And we wanted to protect consumers from unjustified price increases and facility fees, improve and protect quality of care, empower consumers through greater price transparency, mitigate anti-competitive effects of hospital and provider consolidation, reduce price disparity among providers, and increase the state's oversight of the healthcare market, and support independent, low-cost, high-quality providers, and promote efficient patient-centered care through the adoption of electronic health records and a state health information exchange. So these were all goals that emerged from our interim study. And we had key provisions of that public act that passed in 2015 to ban hospital facility fees and create reporting documents. Certain fees, not all, were banned. Required a cost containment study to make recommendations, including on-site neutral payments, reduced payment disparities among providers, the lower costs for consumers, and it led to the creation of the Office of Health Strategy. Price transparency in pricing as well, to require insurers to disclose the allowed amounts paid to providers, creating a public price transparency website and a way of comparing prices, Surprise billing and network status became a concern of ours as well. We protected patients from surprise emergency room and other medical bills required clear notification of network status. One of the problems we discovered, there was a case not in Connecticut, but out of state. We heard a nightmare story of a patient who was having surgery, and her surgeon called in a consulting surgeon for the procedure that the patient had never met prior to the procedure, but received a $20,000 out-of-network bill after the fact from that consulting surgeon. So that was the kind of nightmares that we were hearing about in terms of a concern about surprise billing and requiring that there be clear notification of network status so that patients would at least know in advance when they're dealing with an out-of-network provider. Also, we required hospitals to facilitate the exchange of patient health information with unaffiliated providers, and that clarifying that patient records do in fact belong to the patient, and made information blocking an unfair trade practice that's punishable under our Connecticut Unfair Trade Practice Act, and for civil liability and increased oversight and on hospital physician practice acquisitions and hospital consolidation as well. And as we see, that has become an ongoing problem in Connecticut. We've been just going through a period where a private equity provider had purchased several hospitals in Connecticut, basically exploited them financially. Prospect Health kind of ran them into the ground, and now they are being bought once again by nonprofit entities in Connecticut after a great disruption in our system. And the facility fees that were in Section 9 of a bill that we passed in more recently in Public Act 23-171 also affected some of the facility fee legislation we had previously adopted, and effective starting July 1st of last year, prohibited hospitals and health systems from charging these fees for certain on-campus outpatient procedures that were provided outside of the emergency department. Also repealed a provision that previously made a violation of a facility fee limit an unfair trade practice. Instead, generally allows the Office of Health Services to impose civil penalties for violations of fee limits starting July of 24, made related changes to existing reporting requirements. And it also did a number of other things, including a ban on anti-steering and anti-tiering clauses and all or nothing clauses in contracts between hospitals and insurers, and restored the Unfair Trade Practice Act, which had been inadvertently repealed previously, and now we restored that opportunity for litigation regarding unfair trade practices. So these are all measures that were in an important bill to try to keep pace with all of the negative changes that are happening that disadvantage patients. And we also made permanent the temporary ban of facility fees that was first implemented during the COVID-19 pandemic. So that so again, we had language that said no telehealth provider or hospitals shall charge a facility fee for telehealth services, and the prohibition will apply to hospital telehealth services, whether provided on campus or otherwise. So that was also included in the June 2024 legislation. So with the takeaways, that we benefited from the coalitions that we were able to build, hard work, and also the luck of having bipartisanship on this, because I had a strong partner in Senator Fasano, the Republican leader of the Senate at the time. So we were able to send a very strong message that these bills started in the Senate, but came to the House, and we were able to get them passed in the House because it had bipartisan momentum coming out of the Senate, and saw this as a really broad-based concern affecting every resident of every state. So it really should not be a partisan battle, and that's why it was important for us in Connecticut to get it underway in a way that had bipartisan leaders of the state Senate involved. And unfortunately, as we see from state to state, that regulation and insurance reform always feels like a sort of whack-a-mole process that we do our best to keep up, but when we sort of close one option for profiteering, something else opens up and is discovered. So we kind of have to legislate again on things that we find out weren't covered by previous legislation. We have to act again when something happens. Again, relationships matter, working across the aisle, keeping lines of communication open. And also, we had another issue, on a slightly different topic, but related to practices. We became aware a few years ago that in some cases the pharmacy benefit managers were barring the pharmacies with whom they had contracts from informing their customers that in some cases it would be less expensive to pay cash for a generic prescription than it would be to put it through their policy where they would have to pay their copay. So in many cases, you might have a low-cost generic drug that might be $10 or $12. Perhaps the patient had a $20 copay, and the pharmacist was barred from telling the customer that it would be cheaper for them to just pay cash for the generic. So we barred that practice in Connecticut. Wound up being the bill wound up being covered by NBC News, and NBC when they came to Connecticut to interview me said they had to go all the way to San Francisco to find a pharmacist who was willing to go on record and talk about the contract that they were forced to sign by the pharmacy benefit managers to impose a gag order on them about not being able to tell their customers that there was a cheaper way to get generic drugs. So again, this is kind of an example of the whack-a-mole battle that we're always fighting and trying to close off one pattern of abuse, and they're always very creative about finding another. But again, be happy to talk about this bill, and Dina, who has really become an expert on this over the years, can obviously go into into greater detail both on the policy and also on the procedures that we went through. Thanks so much.
Thank you, Senator. If folks have questions, please use the Q&A feature to post them, and we'll ask Senator Looney some questions. But I'll just take the host's prerogative to kick us off here. And you told us a story that spanned several years, right?
Yes.
And I think I'm just curious. It feels like a good way to approach some of these problems, especially if there's a lot of opposition, to kind of take it in tranches. Was that your perspective, or was it you just needed more time to figure out how to solve this? What was the thoughts behind the longer the iterative process, I guess, that I would say that you approach this issue with?
Well, I think there were so many issues. It certainly was not possible to do them all at one time in one session, given the scope and scale and the vigorous opposition. So that if obviously our strategy was that if you try to do too much all at once and create too weighty a vehicle, it might collapse of its own weight because it would have too many opponents queuing up against it at one time. So by doing it piecemeal, we were able to get this done every year, every other year, coming back with a new piece of it and doing it in a way that was seen as quite not as much of a wholesale assault on the status quo all at once.
Yeah, thank you. There's a question that was posed. What was your experience working with the Connecticut Hospital Association through the legislative process?
Well, I think there it was very, very helpful to have bipartisan support for this bill. In the Senate, my partnership with Senator Fasano, I think, made the Hospital Association aware that something was going to pass because the bipartisan leadership of the state Senate was on board for the same proposal, and I think that made them more likely to come to the table to negotiate and to work with us on certain things rather than just digging their heels with outright opposition and hoping to kill the bill.
Yeah. Every state is going to have to, handle the hospital association. So, yeah, it's important to talk about that. We have another question. What about the employers? Were they engaged? Did they have a role that they played?
To some extent, not as much as they should have, because obviously in many cases they were going to get savings out of this process. But uh, they were not really major players at the table, but they did obviously recognize that they were going to get some benefits out of this if certain changes were made.
Hmm, interesting. Yeah, I think one of the challenges that often happens around patient billing is it's so confusing to begin with, right? It's hard to know whether you should, demand something different, whether it's legal, whether you're just not understanding it. And when we get these folks calling us, a lot of times they're a little bit shy and embarrassed, like, should I have known better? Was there a way I could avoid it? And I think that that's a challenge we have to overcome to help people understand really what are these fees, and understand how they can how they can read their bill, and whether this is a problem of the insurance not covering, this is a problem of overbilling, or it's just a billing error, right? So I'm sure it's a challenge for your constituents as well.
It is obviously because billing is often opaque. People are not necessarily really fully aware about what's being presented to them when they get it, and there's a lot of confusion. We do have an office of healthcare advocate in Connecticut that does help people who have been denied care and need an advocate. We in another front, and Dina can talk about this a little bit more. We have been able to impact the process of denials of care by requiring that a true peer be be provided by the insurance company that's looking to deny care to deal with the physician who is in fact recommending a certain care, certain medication, certain procedure. There are many stories about that where again there's a great arbitrariness of claims being denied just without any consideration at all, with the insurer basically thinking that some people will just go away, they just won't appeal. So even if the patient and the physician win the variety appeals, the insurance companies feel that they've achieved a win just on the cases that are not appealed, and that's a problem. There was a case a few years ago where we had a case of a boy who had severe rheumatoid arthritis, juvenile arthritis, and his rheumatologist had prescribed a certain medication. The insurance company would not provide it. They wouldn't pay for it. They made him go through a step therapy procedure where he had to spend about 6 weeks taking a medication that his doctor knew would not do him any good. And he was bedridden most of that time. And finally, the insurance company relented, said they would cover what the doctor had originally asked for. And within a week or so, the boy was, up and on his feet again and leading a normal life. They made a mistake, however, in picking this boy to exploit because turns out his mother was a journalist and worked for the Wall Street Journal, and she was able to do a detailed expose of what her son had to go through because of the step therapy requirement. So we have put some limitations on that as well that Dina can talk about as well in terms of the limitation on the areas where step therapy can be imposed, and also some limitations on the time frame for making decisions and appealing denials that try to put patients in a better position when they and their physician are trying to get coverage that a providing physician believes to be strongly necessary and is being resisted by the insurance company.
That's so important. And Connecticut is lucky to have that Office of Healthcare Advocate. A lot of states don't have something similar where people can go and get some help understanding and fighting their bills. So really, that's a really important feather in your cap as well to have that in your state for patients who are struggling paying for all of their medical bills. So I know we're kind of taking up a lot of your time today, Senator Looney, but we really appreciate you being here today. We appreciate your leadership. Working on healthcare myself, I know you probably still have a very long list of things that you want to get to, so we will let you get off to your day. But thank you so much for being here. And if folks have questions for him, please let us know and we'll pass them on. And again, we can continue that conversation with your more than competent staff, Dina, at the end of this webinar. We'll take more questions. So thank you very much, Senator.
Well,
Appreciate you
and
being
Dina can
here.
talk a little more about some of the things we're going to look to raise in 2026 as well. Because as
Yes,
you say, it's a never-ending process. It's always cumulative, always iterative, and always incremental.
Right.
absolutely.
Marty, the other thing I was thinking about too is as far as getting it through, the other thing that ended up being a good fortune was that the House Chair of Public Health was married to a doctor. And so he
Yes,
also had some firsthand knowledge of what was going on. So he was very good about shepherding the bill through the House.
Yeah,
absolutely. Yeah, that was also fortuitous at the time.
great.
And that
Thank
House
you so
chair is
much.
now that House chair is now the House Speaker.
Oh, so even better. Yeah,
Yes, yeah.
train them when they're fresh. Excellent. Thank you so much, Senator. Appreciate it.
Okay. Thank you. Thank you. Always happy to talk about these issues and thank you
Great.
for your advocacy work nationwide on this.
Thank you. Thank you.
Take
Okay,
care.
so for the rest of our audience, we still have more to learn. I'm going to turn it over to Christine Monahan from the Center for Health Insurance Reform at Georgetown. Thank you, Christine.
Hi, thank you, Patricia and Park Team, for having me. So I'm Christine Monahan, Assistant Research Professor, Center on Health Insurance Reform. So at the center, if you go next slide, we're also known as CHEER. We basically function like a think tank within the university. And so we study what's working and what isn't when it comes to health insurance. And we issue timely research and policy analysis that aims to help state and federal policymakers identify and craft policy solutions that strengthen health insurance and bolster the system that underpins it. And we also provide direct technical assistance to policymakers and advocates. Next slide. With support from West Health, I've been leading a project on outpatient facility fee billing for the past 3 years. And as part of this work, we've been tracking state efforts around the country to regulate facility fee billing. By our count, 21 states, crossing geographic and political lines, have enacted facility fee laws, most in the past several years. And as I'll walk through momentarily, these laws vary significantly in terms of what they do and how far they reach. And so the legend on the slide is small, but what the map shows you right now is the number of reforms each state has in place. So some states in the darker blue have enacted several different types of reforms, while others in light blue have passed maybe just one strategy. Connecticut, as you just heard, is one of the real leaders nationally tackling facility fees from multiple dimensions. Next slide. And so for our work, we've identified 6 different types of reforms that states can pursue. None of these are mutually exclusive. So an ambitious state could theoretically do all 6 of these types of reforms. But which strategy or set of strategies is best depends on the issues that policymakers might want to tackle. As our prior speakers have made clear, hospital facility fee billing presents several concerns that you might want to address. Consumers can face high out-of-pocket costs. Total healthcare spending is rising, and so that means consumers, employers, including state and local governments, are paying more and more in premiums. And a lot of this is happening in the dark. Consumers don't know when or why they're getting these bills. Employers and insurers don't have the data to negotiate better deals or steer consumers away from high-cost settings. And policymakers lack useful data to inform reforms. So I'm going to walk through these options in a little more depth now. Next slide. So first up are consumer notification requirements. That's requiring health insurance providers or potentially insurers to let consumers know when they may face a facility fee. Depending on the law, this might merely be a sign on the wall at a facility, or it could be multiple notices, say both in orally and in writing at various stages from scheduling to billing. And to encourage compliance, some states might include a stick. If the consumer isn't notified, then the provider can't bill them for a facility fee. The primary benefit of consumer notice requirements is to increase awareness about the prevalence of facility fee billing and reduce some of that confusion if notices are effectively written. Though that in itself is a challenge. Like, how do you really convey this clearly and simply? I'll be frank though, I'm, a little cynical when it comes to expecting consumers to shop around. If you're a patient in the middle of a course of chemotherapy treatment, you don't want to have to go out and find a new doctor if yours was acquired by a hospital. And for many consumers like Todd, who Patricia talked about earlier, there might just not be many or any in-network independent doctors for you to go to. Nonetheless, as you can see on the map, these are relatively popular reforms, or at least they're relatively easier to pass than other reforms can be. Next slide. Another option for states is to simply protect consumers from the out-of-pocket cost exposure through kind of insurance coverage related reforms. So that might be requiring, limiting the cost sharing for a facility fee charge, requiring insurers cover facility fees, or limiting when providers can balance bill consumers for a facility fee. And while these can offer consumers kind of that short-term out-of-pocket protection, you don't see many states pursuing them, right? And I think that's because these focus on addressing the symptom rather than the cause. And actually, that could make the root problem worse, right? If hospitals know patients are not going to see these bills directly, they might try to charge even more or higher facility fees. And it could make the problem worse in terms of like the broader affordability issue of that just gets shifted onto premium. So consumers do feel it, just not directly. Next slide. So for states that want to get a better grip on things, they might want to explore public reporting requirements or at least a study bill. You heard Senator Looney speak about how data moved the needle in Connecticut and is still being used today to refine its law. And so annual reporting requirements that break down hospital facility fee revenue by location, service, payer, like Connecticut has enacted, that can provide really important information regarding the extent of facility fee billing in your state and tell you who is billing facility fees and for what. Now, some of you may be in states where you have an all-payer claims database, and you might be wondering, well, can't we get that same information there and not have to enact new reporting requirements? Frustratingly, right now, if you go to an off-campus HOPD, your claims won't necessarily include information about the actual brick and mortar location where you got care. Like they might not know that you didn't go to the main campus. It might even just have like a billing off, like a location, the address is for like a billing office that's out of state. And so this lack of transparency can really complicate claims analysis when it comes to facility fee billing specifically. So next slide. So another way states can improve transparency around facility fee billing is to require that off-campus HOPDs bill with some sort of unique identifier so that payers and regulators, researchers can better track facility fee charges. This information could also potentially be used by payers as part of their negotiation to secure lower prices at off-campus locations. This is also a really low burden reform. I've talked to a few hospital regulatory and medical billing experts, and the hospitals just need to, fill out a form, take 5 minutes, fill it out, say, hey, we want a unique NPI for this location, and then update their billing systems to make sure that they're using that right NPI. And CMS is always right throughout the year issuing kind of new coding updates. So they have processes in place to update their coding systems. This is a very small lift, and it won't necessarily move the needle in terms of changing billing practices or prices. That kind of depends on how effectively insurers will leverage the information that gets available to them. But at the very least, it would enable more evidence-based policymaking. Next slide. So a fifth option for states is to prohibit hospitals from charging facility fees for certain outpatient services. I think you've probably all been waiting for that one. And so to date, these reforms have been applied relatively narrowly, focusing on services for which tacking on a hospital facility charge seems particularly egregious or indefensible. Telehealth services, preventive services, or kind of in the more ambitious states here, Connecticut, Maine, Indiana, looking at kind of simple office-based checkups or clinic visits. Some states might want to go further than that. And really, I think you can defensively say, look at prohibiting facility fees for any services at an off-campus HOPD or any on-campus HOPD services that could have been safely and effectively delivered outside of a hospital. Right? The general theory here is that it's inefficient to be paying hospitals extra overhead for care that doesn't actually require hospital-specific services, like standby emergency care. Now, in practice, these bans primarily protect consumers from high out-of-pocket costs that can be associated with facility fees. There's not strong evidence to suggest that they're going to significantly lower total spending, particularly in the long term. Just as Senator Looney said, this is kind of whack-a-mole. You can expect that the hospitals will try to make up any lost revenue from a facility fee ban through other charges, including increasing professional fees for the same service if they employ the physicians or can negotiate rates on behalf of the physicians. But it does provide important consumer financial protections in terms of lowering their out-of-pocket costs. You can go next slide. And so if you want to like really, if your priority is how can we decrease total spending, then you need to be thinking about site neutral payments. I don't have a map for you on this slide because we don't currently have any states that have passed commercial site neutral legislation, but there are proposals out there. The general approach here is to say we are going to pay X, so we're not going to pay any more than X for certain services, regardless of whether they're provided in a hospital setting or a physician's office. And to generate cost savings, that payment level you're saying everyone needs to be at or below will generally be lower than what hospitals are getting paid today, and potentially as low as what your state's independent doctor's offices are typically getting paid for services. And so, just to reemphasize, this is materially different than a facility fee ban, although the two policies really naturally complement each other. The facility fee ban basically just says we want one bill for a given service, and assuming there was a billing professional involved, we want that bill coming from the doctor, not the hospital. But it doesn't put any limits on how high that one bill can be. A site neutral policy is generally focused on that total price that's going to be paid for a service to limit the hospital's ability to extract extra revenue when a service can be provided at a lower cost safely. And so you can kind of pair those and have it go together for administrative simplicity, but they do kind of stand alone too. I can go to the next slide. So before finishing up, I wanted to share just some highlights from a few states that have gone down that kind of public reporting or study bills approach and more transparency. The QR code on the slide will take you to a Health at First Forefront piece that one of Chair's research fellows, Julia Burleson, led, and that has more information, really looked at some of the best information out there. And so we have data from Colorado highlighting how outpatient facility fee billing is a growing problem. Each year, more and more money is being spent on outpatient facility fees. From Maine, Maine's an interesting state. So they've had a ban on facility fee billing for care provided in office-based settings since 2005. But it seems like it kind of fell off the radar of a lot of people there. And so there are some gaps in compliance. But since shedding light on the law, Maine has seen a reduction in facility fee billing through their claims database. And, but it appears that total spending is holding steady. So like I said, we're going down to one bill, but the amount of that bill seems to be kind of have gone up, or it's staying kind of on track with where it was when it was split across two bills. I fear we might be seeing something similar in Connecticut, but there, what the public data kind of shows us right now is that even when you clamp down on facility fee billing for certain services, hospitals can increase facility fee billing on other services. So that's again what Senator Looney is saying. This is a bit of a whack-a-mole. Like, okay, we protected things here, but we have an issue over there. And so, I think if you take any message home from me today, it's that when even small, narrowly targeted reforms can carry some important consumer protections in terms of their out-of-pocket costs. But if you're looking for systemic total cost savings, you need to be thinking about regulating a wider range of services and regulating the actual prices charged and paid and not merely the billing mechanism that is used. You can go to the next slide. Happy to take questions now, but just wanted to reiterate that my team is available to talk to all of you offline and be of assistance. We receive support from West Health to provide technical assistance on this issue, and we have a lot of resources available on our website that you can check out. So I hope you will take advantage if this is something you want to keep working on.
Thank you so much, Christine. Your work is really invaluable, and thanks to you and your team for putting it all together. There are great resources. I encourage everyone to look at it. They update these maps frequently, so you're always on the know and know exactly what's happening around the country. And it might help you identify other colleagues in other states, just like Senator Looney brought in Massachusetts, right? You can tackle these things together. We know that healthcare systems cross state boundaries now, so looking at these issues and looking at the data, as a multi-state situation might be a good way to get some of this policy taken care of and helping people kind of across the hospital system. So thank you so much. Dina, I know that you had one comment about the site neutral. So let's go to you first and just you commented in our internal chat, but would you say this out loud so Christine can?
Sure. It's just that that site neutral is the spot because the hospitals opposed that with everything they had. I mean, you can get them to agree to almost anything, but site neutral is like, and we had, it actually was originally in the Senate Bill 811, and that's what the House had to take out to get the bill passed. And anytime you say the word site neutral, the hospitals just turn like 6 shades of green. And then, it's the end of the world. They're going to, have to close. The world is going to end. So you know that it really would actually get to something real, because the strength with which they oppose it is amazing.
Mm. Thank you, Dina. Okay, so we do have a question, and please use the Q&A box. How do you foresee state legislation advancing in a climate? Whoops, sorry, Modesty, can you put that back up there? Oh, here it is. How do you foresee state legislation advancing in a climate where federal cuts will leave hospitals in a place where they're fighting harder to hold on to every dollar they can charge? Somebody want to tackle that? Dina, you want to take that?
Sure. I mean, I don't, I get what you're saying, that they are potentially in a much harder place, especially since they're going to make new rules about the hospital tax and something. But I also think they have a lot of money that they um maybe don't always spend wisely. And I don't necessarily think it's a good um place where they say, oh, we're desperate for money, so we're going to rip patients off to this degree. Like the facility fees and the way that they charge them are not justifiable. If it was a justifiable thing, it would be one thing. But they buy a doctor's practice, and the same doctor, the same service, the same location that you went to last year is twice as much this year. They haven't improved the services. They haven't improved the equipment. How do they justify that, making the bill twice as high?
Exactly. Christine.
Yeah, I mean, I agree with that. I think those are the right questions to ask. And right where everyone is being asked to be more, efficient and cost sensitive these days. And I don't think hospitals should get a pass from that. We're asking our state legislatures and state budgets need to be really fiscally responsible. Everyday patients and consumers are counting every penny and figuring out how do I best use that. We all kind of need to do our part in thinking about, where we can, make some cuts. And I think there is lots of evidence showing commercial hospital prices are really high and out of whack. And so, I think looking there and thinking what's a rational price to pay, is something worth continuing to think about and talk about. I think this also, I do recognize, certainly some hospitals are in financial trouble, and that just speaks to the greater need for transparency right now, right? Like if we need to know what is happening, if a hospital is in trouble, the state should have data to know that and track that and monitor that, right? So I think this just speaks to, the importance of passing, of having tools in place and systems in place that will provide us information to really know like where does it make sense to make cuts and where maybe we shouldn't be doing that.
Exactly.
Have
Yeah.
you guys seen the combination of the RAND study with the NASHP hospital pricing tool, where you can look and you can see, well, okay, this is what they need to charge commercial payers to break even. This is what they actually do charge. So you can see really whether the hospitals are doing well or not well. And some of the hospitals are doing quite well. And some of them are more in trouble, but some of them, it's not the ones you think, right? It's the smaller ones that need to charge a higher percentage of Medicare to break even. Like Yale doesn't have to charge that high a cost, but they just do charge that high a price.
So when folks when this webinar is over and you close your screen, you'll see a pop-up from the PIRG website with an article that kind of speaks to this, actually. So there has been a study that was done to look at the impact of facility fee prohibitions on the income for hospitals and the impact using the NASHP tool. And so you'll see that the facility fee has the least impact on the overall, financial health of hospitals, and is a really, a great way to get away from the overbilling. It's true, like Dina said, right? We can't solve a particular hospital's financial situation by overbilling individual patients for care that doesn't require that kind of a high price tag. we have spent a lot of time, right, figuring out other ways to give people less expensive care than going into a hospital. We've been trying to move the country to preventive care, right? And this is setting us up for moving people away. We heard about, both Brian and Todd struggling to just go to regular preventive care appointments because of these huge costs. And that's not what we want. We want people going to the lower cost settings, the outpatient settings, taking care of their healthcare problems in the least expensive way. And these facility fees are just making people turn away from care in general. So it's like penny wise, pound foolish. And we really do need to solve a real problem with a real solution. As Christine said, we need the data from the hospitals to know exactly which hospitals are struggling, why they're struggling, and then we can solve that problem independently of facility fees. We don't have any more questions, and we're at the top of the hour, but I do appreciate everyone being on for the whole time. We've had a great discussion. There's a lot of information here. We'll be following up with a recording, so you'll be able to see it again or share it with colleagues that you know would be interested in this issue. And thank you so much for our panelists, for Senator Looney, for Christine Monahan, for Dina, and top-notch support from Manasvi and Noah at PIRG. So thank you all. Have a great day.
Thank you.
Having us.